So we're going to transition in our agenda to a really exciting portion where we are going to hear from a Reactor panel and really use this opportunity to reflect on all the incredible things that we have heard today and get their expertise as well. Next slide, please. So joining us for this Reactor panel, we are pleased to have Dr. Joseph Caldwell, Susan Peschin, and Dr. Cordelia Robinson, Rosenberg. And again, their affiliations are on this slide and their full bios are in the participant packet for your review. But we are just so pleased to have each of them here to share a little bit about their work and perspective and just help us reflect and kind of close out our day as we I'm just in awe of everything that we've heard here in day one. So I want to just thank all of you for the incredible questions and the amazing presentations. So if you could transition to the next slide, please. My first question for our amazing panelists is posted here on the slide. Really just looking for your overview of your role and your work and how it aligns with the research agenda, just to give us a little brief introduction about you to help frame our conversation today. So I'm going to start by asking Dr. Joseph Caldwell to respond to question one.
Yeah, hi everyone. Hopefully you can hear me. I'm having some internet issues in my neighborhood, but so if I cut out, somebody please let me know, and hopefully it stays stable. Well, I thought one of the roles that I play right now is I serve on the Federal Raised Family Caregiver Council. And so I thought I'd speak a little bit to that and how that relates to some of the discussion today and then some of the activities hopefully in the future. So I think most people know the RAISE Council formally got underway about a year ago. And this happened through really the advocacy of aging and disability advocates that got a bill passed in Congress. And then the committee or the council was formed about a year ago, and there's 15 non-federal members and about 15 federal agency members. And really where we're at right now is working on, there's really two products that the council is working on. And the first is this initial report to Congress. And the way to think about that is it's sort of a framework where it'll have about, well, the latest iteration looks like it'll have about 5 major goals. And then within those goals, they each have about 5 or 6 recommendations. And I think the way to think about this initial report is it sort of sets the framework. And it's very much modeled on the NAPA Council and the Alzheimer's plan. So I think you can kind of get a sense of what it might look like if you look at that plan. And you know, the good news is Respite has been very much on the forefront of all the discussions. There was a request for information that ACL put out, and Respite was, you know, at the top of what people recommended. So within that first report, there's really, I think, 2 goals that kind of relate to the discussion today. The one is around services and supports, and there's a specific recommendation in there to, you know, increase the availability of respite across all populations. And then there's another goal that's specific to research. And so that's another, I think, placeholder for a lot of the discussion today. So that first report, like I said, I think it's kind of a basic framework. What's more important, I think, is the strategic plan, which is really the second product. And that will have the very specific actions that go under those overarching goals. And I would just challenge everyone to really think about that, you know, because we want very specific actions. These are things that federal agencies could do or should do. So think about is it NIH that we want to do something around respite research? Is it the National Institute on Disability, Independent Living, Rehabilitation Research, NIDALER? Do we want them to do a specific, agenda around research? Or do we want, federal agencies like CMS and the Center for Medicare Innovation to do a demonstration project and test, the impact of a Medicare respite benefit? So these are things that have sort of come up in a discussion, but I would just challenge everybody to think, about those very specific recommendations or action steps that would really be part of the second report. And so I'll just turn it back to the next person to present.
Great, thank you, Dr. Caldwell. I think that's an important reminder that somebody's got to do this work, and you can't have a plan without identifying who's responsible and whose role. And I think I've been a part of a lot of failed strategic planning efforts in my lifetime, and getting from the plan to action is always the most difficult part. So I really appreciate that perspective. Let's transition over to Susan Peschin. Your time here to share a little bit about your work.
Sure. Hi, everybody. It's been a pleasure to join you today. I'm Sue Peschin, and I serve as President and CEO of the Alliance for Aging Research. We're a national nonprofit. We've been around since 1986, and our mission is to promote research as a way to enhance aging and health. I have been a big fan of ARCH and of the Lifespan Respite program for a long time, since before I've been at the Alliance, and was just really happy to serve with a lot of other experts who knew a lot more than I do about this space on the advisory committee for the report that came out. And it's great to sort of see all of this come to fruition. I think that, Ray and Jill and everybody else who's been involved has just done amazing work in meeting all of the, expectations and really trying to meet the goals to get to where we need to get to with this. In terms of our organization, I come at this from more of a patient advocacy perspective. And so I look at a lot of this from the advocacy lens. It's interesting because since the time when we kind of started the work on the report, I've seen a lot more. We've all kind of experienced a lot more. And one thing that has occurred to me in the work that we've done over the years with a lot of focus in Alzheimer's disease is, I think, like the threshold for evidence is much more challenging in these areas than it is in, we do a lot of work in the clinical development space. And so the kind of difference in a controlled clinical trial, RCT, versus this type of a research space can be very challenging. And so I've just been thinking a lot as people were kind of going through the amazing work that you've all been doing about that as an issue, about cost effectiveness as an issue, which I know we're going to talk more about tomorrow. And looking at this from the advocacy lens, the big kind of theme that kept coming up for me throughout the day was you can't do a lot of research on something you don't put a lot of funding into. And so that's kind of like the conundrum that I think we're in, trying to kind of make the case for more funding by doing research, but you can't do research on things that you don't fund very much. So that to me just kind of rose to the top of today's discussion. And the last thing I just want to mention as a first reaction, and I know, Kim, you're going to ask us more questions, but I did respond, Susan Vaughn, to your point about families of people with disabilities. And I do think that there is more of a bridge that we all need to build between the patient disease communities and the people with disabilities communities. So I just wanted to acknowledge your comment. I thought that was a good comment. And we should all be doing more to kind of work together around that. And if you had more specific ideas, I know my organization would love to hear them.
Wonderful. Thank you so much for sharing that. I absolutely love, I gave you a big amen in the chat about your comment on you can't research what you don't fund. And I think as a researcher, that's always a challenge to find funding for our research. But the problem is we're really looking at a community-based intervention that is poorly funded, right? And so even if we can fund a research project, how do we sustainably ensure that an effective evidence-based community intervention is sustainable in our communities? And that's difficult without funding. So thank you for elevating that really, really critical point. So great. So we are going to transition to Dr. Cordelia Robinson Rosenberg for her remarks.
Okay. Thank you. And thank you to the whole panel for this opportunity to be here. In terms of kind of my role, I'm at this point in my career, Professor Emerita of Pediatrics at University of Colorado School of Medicine. And so my role is somewhat different than what it has been through my career. I have been within the University Center of Excellence in Developmental Disabilities and Maternal Child Health LEND program system, if you will, for a number of years, starting in Nebraska, then South Carolina, and then here in Colorado. And a particular area of emphasis has been early intervention with children with complex medical conditions, and especially working with care coordination. But more recently, I've been working particularly in advocacy around the needs of individuals who are duly diagnosed in terms of developmental disability, autism, and behavior that puts them at a danger to self or others. So in working with that population, what I'm struck with is the pertinence of much of what we've heard today, and the similarities across the age range. So even though we've heard about early intervention and the needs there, we've heard about aging. I'd also put on the table those adults with developmental disabilities, many still living with their family, others in supported living situations. But when you peel away some of the details, the basic core needs are the same. And I think that point of view can be something that would help us create the common cause across different populations. We've heard a lot about care coordination today, and I think there's a really critical intersection between models of care coordination, family navigation. There's a plethora of titles that are given to it, and the role that respite can play in moving the agenda along. Certainly, I've been struck over the years at the difficulties we can get into sometimes with making, with it becoming very bureaucratic in terms of the requirements that agencies feel they have to put on something like respite care. And I've struck with what we heard today. I mean, certainly reminders of that, of those perspectives that we need to be prepared to deal with. So just to wrap up, my background is in nursing and developmental psychology. And as I said, I've worked for substantial periods of time in those 3 different states, and I'm struck by the commonalities that we have going back to the mid-70s, coming up to the day today. The themes we've heard, I've encountered throughout that period of time. So, thank you.
Thank you so much for those remarks. I love that idea of the common cause and thinking about how do we take this opportunity across conditions and across the lifespan to build some collective impact around promoting respite and respite-related research. That's a really great thing to think about and look forward to with these great connections we're making here today. If we could transition to the next question, we'll put that up on the screen for a second. Asking our panelists to just share a little bit about what stands out to you in your work and as you've reflected on the day. We've heard a little bit about that already, but what are the key takeaways from today's presentation and discussion? You know, is there anything new, anything insightful, anything really important that you think is important that we want to make sure we elevate and reflect on? So we'll again go in the same order, and we'll start with Dr. Caldwell.
Yeah, let me share a couple thoughts I had. The first was with the annotated bibliography on respite, which is an incredibly useful document, and kudos to Arch and Ray for doing that. It actually, I love it because if you're working on a proposal, you already have your lit review there. So I use it a lot. But I was looking at the updated version, the 2020 version, and I was sort of trying to get a sense of where the new studies were happening, what kind of research, over the past, 2 iterations of that had really happened. And you can really get a sense of like where good things are happening and where there's still big gaps. So, it might not come as a huge surprise, but, most of the new studies were occurring in older adults, particularly dementia. And the second major area was children. And like some of the other reactors has said, there's still a big gap for research on adults with developmental disabilities or adults with disabilities. Essentially, there were no new studies. The last study in the bibliography is actually from 2008. So it's been 12 years since we've had, a new study on respite for that population. So I think that to me is very striking. And the other thing in the presentations, a common theme that I really sort of picked up on was this idea of kind of making respite person-centered or person family-centered. Joe specifically mentioned that, and in other presentations there was like, making sure the respite is, this the right type at the right time and the right amount. And I think that is just a really fruitful area because of all the work we've seen around person-centered planning and assessments. And, there's a lot of interest in caregiver assessments and sort of defining more what that is and that conversation that happens to really get a sense of what the caregiver really truly needs. So I really think that's a fruitful area for research and also just understanding what exactly caregivers do want, using that assessment data is part of the research. So I think that was an area that really struck me as a common theme.
For sharing that. We'll transition to Susan Peschin.
Sure. So I thought, Dr. Utz, the description of the work that you're doing, and I just wrapped up my tenure on the National Advisory Council on Aging. And I remember this concept clearance originally when they, from a couple of years prior, and how excited I was. I think that there's got to be more opportunities at NIH to fund this type of work. And I was really struck by what you described about how half were not satisfied with their respite time, and in some ways folks need the coaching about it really being a time for them rather than a time to just make sure they can get the rest of their chores done and go back to family caregiving, which does kind of go into the second part of the definition, was resulting in measurable improvement. But the other thing that I was thinking about throughout the day with all of these presentations was, again, the threshold for evidence in terms of what is considered significant. I think that, that's kind of the next step here. And the reason why I was thinking about it, and Rainey may actually be familiar with this, the Agency for Healthcare Quality did a review of non-pharmacologic interventions for people with Alzheimer's disease. It was like a big review that over the last maybe 2 years, most of the interventions that they studied, they found there wasn't enough evidence for. And it was very disheartening because, nursing home regulation at CMS is, has notes that says try non-pharm approaches first. Well, if nothing is considered evidence-based and they just have like a whole list of stuff to do, what are they supposed to do? So I do feel like we're hitting a little bit of a wall that we're going to need to overcome around what is considered statistically significant in the way of outcomes here. I think your study, Dr. Utz, kind of takes it to a level that it hasn't gone to before. But at the same time, I do feel like that's a gap that we need to kind of figure out, because I don't want to hit another wall like they hit at ARC with the non-pharm interventions for dementia. And I feel like we're going down that road. It's almost like you can't win unless you're able to create a similar model to an RCT in this space. And I almost feel like that there's an opportunity here to kind of create new definitions for what constitutes statistically significant outcomes. So I just wanted to put that out there because it just seemed like a recurring theme for me throughout the day.
Thanks so much for sharing that perspective. I think that's an incredible point. I just have to share a little anecdote. So I'm involved in the International Short Break Association and so honored to learn from our international partners. And that group traditionally has not been very research focused. There are some researchers who participate in that work. And as a sort of newbie to that group, as a researcher, I can't tell you how many people internationally ask me, well, why do you have to research respite care? Like, we just fund it because we know it's important and works. And and obviously we're here to talk about why we do need respite related research, but I think there's just in other contexts, more sort of assumptions and awareness that it is important, and instead of continuing to research and prove why it's important, let's focus on increasing the quality and access to it and other things. So I just think it's really interesting from a global perspective how people look at what we need to research and why, that I wanted to share. Great. Yeah.
Is it okay for me to address a little bit of that?
Yeah, absolutely.
I love that you brought that up, Sue. And actually, Kim, your comments also really make me think, why do we need to prove it? It's good, it's necessary, it's helpful. It brings me back to the poll question as part of today's program, what do you think policymakers want to know? And I don't remember the percentage, but the vast majority of people said, you know, cost benefit analysis, cost savings. I think that's one of the main reasons we need to know. It's not for us, we're the choir, right? But it is to make sure that the right policies can be in place so that we can move respite forward and other respite-based programs that really support caregivers where they are.
Yeah, I really want to make sure people understand, I am not saying that we should not be doing research. I think Rebecca, I saw her sort of nodding when I was mentioning, I'm not saying not to do the research. What I'm saying is the measures that this type of research are judged against, that we need to define what our measures are and kind of put that out there almost as another area of research. Because otherwise this will get kicked to the side of the road, just like the non-farm dementia interventions are. Because if we don't meet the same research thresholds that RCTs, and I don't even know if it's possible to, Rainey. So I think that for this type of qualitative research, we need to have what's acceptable in the policy arena to show that this stuff is effective.
And Sue, I totally agree with you. So I actually didn't hear you as saying that we shouldn't do research. I don't know if anybody did, but I sure didn't.
Okay.
And, I was actually, so to my second point, so I'm glad you raised it again, is that we did fund a project, and I think maybe this is what you're referring to, which is very different than the ARC project, that was around determining which of the programs to support family caregivers are evidence-based. But it wasn't randomized controlled trials. It was very much based on other evidence around the programs and the ability to replicate those programs as well, so that we could put together a database there's more than 40 now programs that exist to support family caregivers. And that database would be available to whether it be community-based organizations or healthcare systems, health organizations, so that when they go to look for the programs that they might want to implement for their population in their setting, they know what exists and which ones have some evidence base. So, you know, that term evidence, I think, can be used more loosely in some settings and more stringently, as you're saying, in those randomized controlled trials in other settings. But the folks who have done that research it's David Bass at the Benjamin Rose Institute, and should probably be a part of some of these conversations moving forward, because they have done very intricate, detailed research along these lines, but it's still not randomized controlled trials. And yet there's a lot of value there. So I'm really agreeing with you and trying to fill in a little bit of information there.
I love this conversation, and as a little teaser, this is the kind of conversation we're going to have tomorrow on day 2 in the roundtables. So, you know, keep the comments in the chat going, but also there'll be robust conversations around outcomes and what's important to measure and cost benefit research tomorrow in the roundtables. So I'm going to, just for sake of time, Jill wants to.
Sorry, I don't want to.
No, go ahead.
He wants to keep us on track here, but I just want to make sure that everyone is aware of this whole conversation and discussion that the expert panel had back in 2015 around different levels of evidence, and that we don't have to jump immediately to randomized control trials. In fact, we laid out a hierarchy of different levels of evidence that we felt would be worthwhile. And I hope we're going to continue to have that discussion in the new committee as well, about what kinds of evidence we really need to be able to make the policy case. I totally agree with you, Sue and Rondi, so thank you both.
Wonderful. I love this conversation. But I want to give an opportunity to Dr. Cordelia Robinson Rosenberg to share her key takeaways from day 1 of the summit.
Right. Well, thank you. And similar to Joe and Sue, Dr. Utz's work around making respite availability person-centered, I'm finding really exciting. I mean, and feel like it really goes to a core of what needs to happen, because I think over the years we've heard over and over about parents' hesitancy, in my case working with families with younger children, hesitancy to use respite care because of concerns of the adequacy of training of people, other concerns that were mentioned today. So that idea of allowing people to define what their goals are for receiving respite care, I think is really exciting. I especially liked the taxonomy for how to define respite care programs and trying to create some assessment of comparability across programs, because there's a huge range in terms of what's needed with different populations. You have a common core, but then you'll see some variations. And then finally, what came through to me is also the acute issue of who's going to deliver. So what personnel capacity do we have for respite care growing? Okay, thank you.
Thank you so much for sharing that. And again, a teaser for tomorrow's roundtable. We'll talk a lot about provider confidence and training and how important that is as we think about who delivers train those individuals. So great. I want to get us transition to the next question. So if we could get that up on the screen. You saw some of the chat questions that were being posted during the break that were incredible. I love the research questions that were coming across and really helping us to think about what do we need to understand about the impact of the COVID-19 pandemic on respite care. And so I am really looking forward to pulling those together and continuing to add to that list of COVID relevant research questions. So I want to just hear a little bit from these amazing panelists on what they think, not only specifically what questions should be asking, but how has the COVID-19 pandemic impacted this work in respite-related research? So again, we'll start with Dr. Caldwell and see what he has to say about how do we do this work in the context of COVID.
Yeah, I also really appreciated the comments in the chat. I guess a couple things I would add, stating the obvious around the use of remote technologies and technology. I think that is a big area of research in light of COVID, and actually just I think a good way to go with a lot of the interventions. So testing the efficacy of those remote or online versions of interventions. The other thing, I just wish we had better, very timely nationally representative data on how caregivers are doing during the pandemic. We really have no idea. We don't know how much more care they're providing. We don't know, the impact, the racial, ethnic sort of impacts, in terms of how much care people are providing or how they're doing during COVID. So I think that's just a bigger issue, that we don't have timely national data. And on the one presentation where they took questions out of the Children with Special Healthcare survey around respite, I think, that's the stuff I think we need to watch out and make sure that we have questions in those surveys, in the few surveys that we do have, around respite. And, the last thing I would add is just a lot of states have increased flexibilities and, during COVID for people receiving Medicaid, home and community-based services. So a lot of states have increased self-direction options. And I think that's worthy of studying. So families that have access to self-directed respite, where they get to choose who they hire or they get to control a budget, there's some indication that, during the pandemic, obviously the flexibility of that model just gives people options to get their services continued, because they have the flexibility to hire someone that they might trust, maybe another family member or someone, to come in and deliver some services versus, having a stranger or an agency person come in. So I think that area, like testing self-directed models, I think would be a good area to pursue for future research.
Great. Thank you, Dr. Caldwell. Peschin, your thoughts on COVID and the impact on respite-related research?
I mean, the only thought that I had is that there's a lot more interest at some of the institutes, NIA included, in pragmatic studies. And I don't know if there are opportunities, for funding in that area, but I think if this is going to drag out at least for another 6 months to a year, and if there are opportunities for researchers to consider applying for pragmatic design work, I think this is a good area for that. That's my main thought on it.
Great, thank you for sharing. Dr. Cordelia Robinson Rosenberg, any additional thoughts on?
And for the future, it can just be Corey. So, yeah, the thought that struck me in terms of what I'm hearing, and I'm doing research in autism, is a kind of a mixture of reactions from families. Some are experiencing relief in that their child, in staying home, does not have that anxiety that otherwise presents itself from being at school. So it's kind of a mixed picture in terms of the impact on families, and certainly worthy of looking at. And I have heard of some survey research that's being put into place about the impacts on families. The other thought that occurred is the issue of inequity in terms of access, because the strategies that are available in dealing with it are technology, and so many families don't have that access. I have, at least in our community in Denver, the cable provider has done some things to try and step up availability of online access for families who don't otherwise have it. I assume that's probably happening around the country. So it would be good to, particularly in those cases, know how that does help the family going forward. So
that's a great point around the access to technology. That came up as a theme in the global study that we did, looking at the impact of COVID on respite services. And it wasn't just the access to the technology, it was the ability to use it. So, I think about, my aging parents, and if I put an iPad in front of them and told them to use that to have a virtual support group, they would, even if they had good internet access, it would be very difficult for them to engage in that way. And just the impersonal nature of that for my parents' generation, I think, is a big barrier to that as well. So lots to think about and study around that technology. Wonderful. Well, it's so great to hear from these incredible experts and their thoughts on these key questions here. We want to take the next couple minutes to just offer you guys the floor for specific questions that you have for these panelists that you want to share. So I know there's been lots of comments and dialogue in the chat, but if there's any additional specific questions for our panelists that you want to share, we'd ask you to post those now and give you a little bit of time to engage with our panelists. There's a question from Marissa Bueno that says, we may have to make a policy case to a legislature and possibly a governor that say they would like to gut public programs. What are the core pieces of research and the core arguments that we can use to help build support for respite and continue to build effective respite services? So wondering if there's a panelist that wants to respond to that question.
I mean, I think delayed institutionalization would be a big one in that case. I think that's probably would be at the top of the list.
Is there good research on the cost benefits? I'm joining the cost benefit group tomorrow for this very reason, because I think the whole argument around this actually being a sort of a workforce initiative of sorts in our state, to really create a, especially given where our demographics are going, would be interesting. And so part of it is thinking about what are the arguments that where we can present truly strong evidence as much as possible around the costs and benefits. But I'm curious if there are pieces out there you would highlight and say, yes, take a look at this, or that kind of thing around delayed institutionalization and the benefits of that. But also the outcomes, other outcomes besides the cost benefit analysis. I'd like to hear those too.
I'm going to lean on Jill and Ray here to,
Yeah,
there's not a lot.
there's
Go
not.
ahead.
That's what I was going to say, Sue.
Yeah.
Especially when it comes to cost benefit information. There's not as strong evidence in the literature as we would actually like to see. And some of that is because of methodological issues, not because we don't believe the services are cost effective. It's just a very difficult thing to research, especially in the respite arena. But we do have lots of other wonderful outcomes, such as reduced stress among family caregivers, and we know how stress affects caregiver health and well-being. The effect of respite on increasing social relationships and how that can impact social isolation among family caregivers. So we do have other very meaningful outcomes as well.
I could jump in on that too, just for a second. I think there is perhaps a risk of, until the evidence is clearer on the true impact of respite on various cost measures, there's a risk in promoting the service on the basis of it being a cost-cutting or cost-saving service. Because then if it doesn't work out, the program is damned going forward, even if there are quality of life improvements for caregivers that have accrued, even if it's cost neutral. And I'm increasingly of the belief that quality of life improvements may well be worth an added cost, which just reframes the conversation to what is important in society going forward with respect to caregiving and maintaining quality of life for both the caregiver and the care receiver. It's a tough conversation to have, particularly in a political environment. But I certainly think it's one that we can add to the mix of important questions to look at.
Great conversation. I think something we'll talk in the roundtables about tomorrow, as well as, you know, what are we talking about when we say costs? What's the economic and the societal costs that we need to look at and measure as well. So really framing that conversation will be helpful tomorrow. I see a couple questions related to COVID. So one in the chat from Sarah that says, is there an opportunity to capitalize the COVID-19 experience and risks associated with institutional care to leverage increased respite and other supports for community-based supports? Wondering if any of the panelists want to react to that question.
I do know that home care has done that quite. Home care companies have really sort of used COVID-19 as a way to say, like, it's so much safer and this is why we need more coverage for it. I think to Ray's point, going back to the cost effectiveness issue, that's also been an issue with the waiver programs under Medicaid for home and community-based services. A lot of times people think, oh, it's so much cheaper to keep people in the community, and oftentimes it's actually more expensive on paper. but it has benefits for people being able, if they want to stay at home and be in their community and all of that. So, you know, it gets tricky in that regard. But the home care companies like Home Instead, for example, we did a project together recently, and they really made a big deal about how it's very different than congregate care, and there's much lower risk of infection and all of that. And I think, again, like from an evidence perspective, I mean, we're as federally funded care and state funded care, the tracking, you know, of deaths, even though it hasn't been perfect, in nursing homes has really been highlighted in the press. You could argue that we don't completely know the number of people, you know, who really have had COVID-19 deaths in the home. We have some of those, but they're not fully captured. They're not always captured as COVID-19 deaths.
Thanks for that response, Sue. So I'm just conscious of our time, and I can't believe this day is already coming to a close. This has been so great. The time has flown, and I want to make sure that we take a moment here at the end to sort of wrap up before people have to log out at 5. So Marsha, if you could just pull up the PowerPoint, thank you. Before we go, I really would love for everyone to just pause for a moment and respond to the day 1 reflection question that's posted here. And if you would take a moment to just post in the chat one key takeaway from day 1, you know, what's really resonating with you. It could be a question, it could be a comment or a theme you notice, but really just would love to hear sort of what's in your mind as you're thinking back on day 1 of the summit. And please post those in the chat so that we can harvest that information and benefit from your key takeaways as we close here today. I see folks starting to post in the chat, so thank you for that. If you want to go to the next slide, Marsha, then I'll just kind of wrap up as people are reflecting on that. So again, want to thank all of you for being here today. A special thanks to our incredible presenters and our panelists for helping to kind of pull this day 1 together at the end, and a reminder that we want you all back here tomorrow for day 2 of the summit. We'll begin at 1 p.m. Eastern time. The way to connect is the same as today, so same Zoom link, and can't wait to continue these conversations, hear from more incredible presenters tomorrow. And a special feature of tomorrow is our roundtable discussion, so really looking forward to having more robust discussions with all of you as participants, and hope that you guys rest up well tonight, get your respite so you're ready and fueled and energized for an exciting day, continuing the conversation about how to advance respite-related research in day 2. So thank you all, and again, we'll stick on for a little bit if you want to post in the chat those questions if you didn't get a chance, but appreciate all of your time, and we'll see you tomorrow.